Hypocalcemia is not a feature of thyrotoxicosis, it is a feature of hypoparathyroidism, pancreatitis, hypomagnesemia, but not thyrotoxicosis. Which dyscirculatemia will be found in thyrotoxicosis, especially in Indian subcontinent, doctor. Thyrotoxic individuals may. Potassium. So they will have an associated hyperkalemia. Is common in the people who are having thyrotoxicosis is what you need to remember. Then metabolic alkalosis with urinary chloride excretion being low is a scenario where will you basically come across. Okay, we will take a couple of minutes on this. See doctor, acid base disturbances is a very easy topic honestly. What is called inhalable acid? CO2 is nothing but an acid. Inhalable acid it is called. Volatile acid otherwise. Whenever CO2 accumulates, what do you have? Acidosis. Whenever CO2 decreases, what do you have? Alkalosis. Who is the only person in the body, thing in the body which can make CO2 go up or down? Lungs. So, respiratory acidosis is characterized by high CO2. Respiratory alkalosis is characterized by low CO2. How can respiration can lead to CO2 excess? By hypoventilation or hyper? Hypo. Hence, respiratory acidosis will occur whenever there is a hypoventilation. Respiratory alkalosis occur whenever there is hyperventilation. Kadam? Then comes the metabolic. Metabolic is decided by what? Bicarbonate. Low bicarb is acidosis, high bicarb is alkalosis. Okay. Now, what leads to metabolic acidosis? Anything that exhausts the bicarbonate. If some other acid is produced in the body, that can be lactic acid, that can be ketone bodies. There are 10 causes for what? Metabolic acidosis. Who is the main excretor of bicarbonate in the body? Or reabsorbent of bicarbonate? Kidney. So you have one more entity called renal tubular acidosis, where if the kidney is not functioning, you lose all bicarbonate without reabsorbing, and that lead to low bicarbonate and hence lead to acidosis. Right? Then what lead to increased bicarbonate in the body? This is the most important point you need to understand. All the remaining are easy. It is also easy provided at least once you have gone through that. Metabolic alkalosis is associated with what, doctor? Alkalosis is associated with increased bicarb. What lead to increased bicarbonate reabsorption into the body? The most important mediator of increased bicarbonate reabsorption is aldosterone. Whenever aldosterone is there, high aldosterone is there, that lead to development of increased bicarbonate reabsorption and lead to development of metabolic alkalosis. How can aldosterone can be high? There are two possibilities. One is called primary hyperaldosteronism. What is primary hyperaldosteronism? If you are having an adrenal adenoma, it is overproducing the aldosterone, which is a mineralocorticoid. Aldosterone will cause increased bicarbonate reabsorption in the kidney and lead to development of metabolic alkalosis. Second possibility is what? Secondary hyperaldosteronism. When do you call secondary hyperaldosteronism? Whenever we are hypovolemic and dehydrated, that will decrease our renal plasma flow, and that stimulates the renin production, that lead to angiotensin production, that lead to increased aldosterone production, and that aldosterone will lead to bicarbonate reabsorption, and such a hyperaldosteronism is called secondary hyperaldosteronism. All secondary hyperaldosteronism, what is the cause? Hypovolemia. So if you want to treat secondary hyperaldosteronism, how will you treat? Treat the hypovolemia. How can you treat hypovolemia? By giving saline. So you will give saline, treat hypovolemia and decrease aldosterone levels, and automatically bicarbonate will normalize. Hence, this metabolic alkalosis, which is due to secondary hyperaldosteronism, which is due to hypovolemia, is called as saline responsive metabolic alkalosis. Whereas the one which is due to primary hyperaldosteronism is called saline unresponsive metabolic alkalosis. And how will you treat this condition? You have to give aldosterone antagonistic drugs. What are they? Spironolactone, triamterene. We read all diuretics, no? They are all aldosterone antagonistic agents. So you will give spironolactone, which is aldosterone antagonist, to treat the metabolic alkalosis which is due to primary hyperaldosteronism, and saline to treat the metabolic alkalosis due to secondary hyperaldosteronism. Right, doctor? Now, whenever metabolic alkalosis is there, what happens to the urine chloride excretion? Urinary chloride excretion. Generally, all forms of metabolic alkalosis will have a low serum chloride level. Low serum chloride. And only one scenario. Urinary chloride will be low whenever the alkalosis is because of hypovolemia. Chalo, how will you remember this, and why it is because of? Why is it like that? See, there is a metabolic alkalosis. All forms of metabolic alkalosis causes low chloride, serum chloride. Why should they cause? Very simple. In all states of metabolic alkalosis, what is fundamentally happening? The renal proximal tubule is reabsorbing more amount of what? How will metabolic alkalosis occur? If the proximal tubule is reabsorbing more amount of bicarb. In the proximal tubule, the bicarbonate and chloride both are negative ions. Both are beautiful princes, doctor. Only one princess it can marry, the other it can't. So if bicarbonate is more reabsorbed, what happens in proximal tubule to the reabsorption of chloride? It will be decreasing. And then when chloride is not reabsorbed, what happens to serum chloride? It will become low. That is the reason all forms of metabolic alkalosis have got low serum chloride and increased urinary chloride. You agree? But what is the only exception? If the alkalosis is due to hypovolemia, then the urinary chloride also will be low. Why? If you are hypovolic, means what you don't have in the blood? Volume. Generally, what is meant by volume? Saline. Saline means what? Chloride. When the plasma itself is deficient of chloride, how will chloride will be high in urine? It won't be, na? Because how is urine formed from plasma only, na? So, urinary chloride will be low whenever metabolic alkalosis is because of what? Hypovolemia. But all other forms of metabolic alkalosis may urine chloride will be high and serum chloride will be low. You don't need all this to get a PG seat. But because your teacher is a general medicine guy, he will have temporal lobe seizures when fluid electrolyte topic comes. So that is the reason we are equipping. Suddenly all your faces have become, oh, itna hai kya? So ye sab yaad rakhne ka cheez hai kya? No. This all bullshit doesn't require to enter into the 200 pages book. That is a very pure book. Very few things that we can remember, only we will write there. Right? So, but some general principles you must know. Kidney, renal tubular acidosis and all those things. Next is another seizure generating topic, anion gap. Anion gap. I don't throw seizures, but at least one simple question I will ask. That's the reason we should not put too many good questions in only one paper, because we don't really get time to look into it. But at least all this must give you inspiration to go back home to read. For entrance, what topic? Fluid electrolytes, acid base disturbances. Today evening only, start a white paper in the reading room. That should be the goal. Anion gap. Ideally, what is the meaning of anion gap? English meaning batao. Anion minus cation, it should be ideally. Then only you call anion gap. Should call. But how will you calculate anion gap? Sodium plus potassium minus chloride plus bicarbonate, you call it as anion gap. जो हम कर रहे हैं कैटायन से एनियंस को निकाल रहे हैं, इसको कैटायन गैप नहीं कह रहे हैं. क्या कह रहे हैं हम? एनियन गैप कर रहे हैं. बुरा अंग्रेजी क्यों ऐसा हो गया? If you look at cations, there are measurable cations like sodium, potassium, and unmeasurable cations in the body. Unmeasurable cations. So these unmeasurable cations and measurable cations is equal to unmeasurable anions plus measurable. What are measurable anions? Chloride and bicarbonate plus unmeasurable anions. Protein, for example, protein has a lot of anionic charges on that. It contributes to unmeasurable anions. Should this equation is correct or not? Definitely. Otherwise our blood will be charged blood. If this is more than that, you will be cationic blood or anionic blood will be there. If this is more than that, it should not be. Right? Yes or no? Like Superman, He-Man, Batman, Electric Man. We don't have Electric Man, right? Now, you rearrange this equation. If you rearrange this equation, ideally I should write this first. Unmeasurable anions plus measurable anions is equal to unmeasurable cations plus measurable cations. Okay? You rearrange this equation. Unmeasurable anions minus unmeasurable cations should become measurable cations minus measurable anions. That is the reason we measure the cation sodium, potassium and subtract measurable anions chloride and bicarbonate from them, so that indirectly you will get an idea as to how unmeasurable anions minus unmeasurable cations are there in the body. Hence this is called anion gap. Why we need to calculate? For example, if you are having high lactate, high ketone bodies, what do they contribute to? Are they measurable or unmeasurable? They are unmeasurable. And are they anions or cations? Anions. So when lactate and ketones increase, unmeasurable anions will increase, and that lead to increased anion gap in a case of metabolic acidosis. Hence this is called high anion gap metabolic acidosis, which is caused by lactic acidosis, ketone bodies, or if you have administered ethylene glycol like agents, they are all contributory to what? Unmeasured anions. Hence the increased anion gap, which is calculated by subtracting measurable anions from measurable cations. Agree? Then you have another scenario of metabolic acidosis. That scenario is called renal tubular acidosis. In this, what is happening? There is a proximal tubule and there is a proximal tubule, descending limb, ascending limb, and distal tubule. Normally, kidney is supposed to do what? Reabsorb bicarb. When will renal tubular acidosis will occur? If kidney is damaged, why should acidosis should occur? Normally, it should reabsorb bicarbonate and prevent acidosis. It is unable to reabsorb bicarbonate. When it is unable to reabsorb bicarbonate and lost into urine, who is the competition for bicarbonate to get reabsorbed? Chloride. Then chloride will tell, don't worry proximal tubule, did bicarbonate reject you and went and liked that USMLE boy? Don't worry, I am your mama's daughter, from school only I have a crush on you, so I will get reabsorbed. So there is an acidosis, but what kind of acidosis? There is a low bicarbonate, at the same time commensurately increased chloride. So if this decreases, that increases, overall will there be any effect on anion gap? No. Hence an acidosis caused by renal tubular acidosis is called what? Normal anion gap hyperchloremic metabolic acidosis is the name given for Nizamiya, Ulum, Bahadur Siddiqui. Big name is there actually for normal anion gap metabolic acidosis, but what is that big name? Hyperchloremic normal anion gap metabolic acidosis, which is renal tubular in nature. Anyway. Now doctor, if we go like this doctor, we will not finish 200 questions, but anyway, point is general medicine is place where you need real discussion. After going home, on your mobile phone evening, have a cup of coffee, revise in the medicine video library. You have a video on Gentleman syndrome, Liddle syndrome in nephrology, renal tubular acidosis, anion gap, fluid based, electrolyte disturbances and acid based disturbances. Totally 4 or 5 hours of investment if you do know. Every mock test anyway we will ask you, we won't leave you. But every time you don't keep failing on the same topic, usme maza nahi hai. So somewhere or other you should change the pattern of your writing a love letter to at least win one romance in lifetime. So doctor, calcium antidotes, what is their effect? Typically they can lead to gum hypertrophy, just like cyclosporin can lead, phenytoin can lead, even calcium channel antagonist is a part of that list is what you need to be quite sure about. Charcoal increases the elimination of theophylline and all charcoal eliminatable drugs, एक list है, dialysable drugs list है. Where do you want to do alkalinization of urine? Acidification of urine. 5 drugs there, 5 drugs here. 200 pages में जाने वाला topic बोल रहा हूँ मैं. So today evening only you make this 4 lists: charcoalable, dialysable, urine alkalinizable, urine acidifiable. Which drugs we use this different strategies of drug toxicity management. So hemodialysis, salicylates, phenobarbital, methanol, ethylene glycol, lithium are the classical drugs. Lithium amidoron digoxin. Lithium amidoron digoxin. LAD. These 3 drugs, everything you must know, and tricyclic antidepressants. toxic dose, metabolic dose, therapeutic dose, mechanism of action, effects of toxicity, everything you must know. These 4 drugs. Then doctor, we use methanol in ethanol poisoning, we use tricyclic antidepressants in phenytoin poisoning, and we use hyperbaric oxygen in carbon monoxide poisoning. We use phenytoin in tricyclic antidepressant poisoning, okay. Ethanol in methanol poisoning. You must know the antidotes thoroughly. Then, for diabetes insipidus, which is due to the resistance of nephron to the action of ADH or non-production of ADH in the brain. So what drugs will you use? You will use chloropropamide, chlorothiazide, DDAVP and all these things which will increase the sensitivity of the tubules to the action of ADH. You can very much use. But lithium, demiclocycline, amphotericin B, what will they lead to? ADH deficiency state, nephrogenic diabetes insipidus they lead to. चलो मैं यहां तक आने के बाद अगर ये बात नहीं बताए तो मजा नहीं होगा. What is paradox in diabetes insipidus? Diabetes insipidus होता है diuretic state. Agreed or not? Diabetes insipidus में ADH is not working. ADH is antidiuretic hormone. If it is not working, what should happen? Diuresis. So diabetes होता है diuretic state. मगर उसके ट्रीटमेंट के लिए जनाब आप क्या दे रहे हैं? थायराइड. वो भी डायरेटिक है. एक डायरेटिक को डायरेटिक स्टेट के लिए इस्तेमाल करना उचित या अनुचित है? उचित है. क्यों? क्यों इस्तेमाल करते हैं थायराइड को? Is the question. Now why I am saying this is, sometimes first time you will get doubt in exam hall. That is very dangerous. तो आपको डाउट नहीं आया मगर मैं डाउट दे रहा हूं ताकि आपको एग्जाम हॉल में पहली बार डाउट नहीं आएगा. So that's the idea. Why do we give thiazides? Very simple. Glomerulus, proximal tubule, then you are having this is the proximal tubule, and what is this? Distal tubule, what is this? Collecting duct. And where is ADH acting? ADH is acting on collecting duct to cause the reabsorption of water. What is diabetes insipidus? Why are they losing water? Because ADH is not working, they are unable to reabsorb the water. Okay, that is diabetes insipidus. Okay, doctor. If Telangana state doesn't get water from Krishna, we will all die without water. We still can get water from, what is the other location where water can be reabsorbed? Godavari kahan se aayega? Proximal convoluted tubule. Right? So, if the distal tubule is not working and water is not getting reabsorbed because one ADH is not there to cause water reabsorption, what is the only way that we can help the patient to still reabsorb water? We should go to a place which is not dependent on ADH. Maharashtra jao, Karnataka jao, Raipur jao, Uttar Pradesh jao, kahin bhi jao, magar pani lao. Right? So, we must make proximal tubule to reabsorb water. How will proximal tubule will know that the distal tubule is not working, ADH is not acting? It did not read Harrison like you know. So, how will it know? So, we should make it know. How we will make it know? Proximal tubule को एक अजीब स्वभाव है. वो क्या है? Whenever the glomerular filtration rate decreases, it will immediately realize, oh, GFR decreased, and it will immediately increase reabsorption of water. It will increase the reabsorption of water. See, we used to have one batchmate, conjuice fellow. He won't tell what he is reading, he won't give his books to anybody, he won't even share his lunch box. Very useless fellow. We used to think, let us see which classmate among our class will really fall for that guy. So we used to think like that. But we found he has one small weakness. What is that weakness? If somebody is sick, oh, he used to go extra miles. He used to get food for him, water for him, medicines for him, everything. He used to sit on his side. Nobody used to care. Everybody is in football game, but that guy used to sit on his side. We were thinking, इतना कंजूस, इतना miser, इतना गंदी आदमी, ये कैसे क्यों कर रहा? Actually, that fellow had a childhood experience. He was put in hostel by his parents in childhood only. So, lot of times when he was sick, he was not attended by anybody. So, in spite of all his problems, psychological shortcomings, when it comes to somebody's sickness, he is the first person to be on the side. So, if you want his notes, if you go to his room and ask him, will he give? No. You should apply little hot pats and go with fever and say, will you give my notes, give your notes please? Then he will give. So, proximal tubule also, इसका एक अजीब स्वभाव है. जब भी ग्लोमेरुलर फिल्ट्रेशन कम हो जाएगा, वो नींद से उठ के पूरा वाटर को रीअब्सॉर्ब करेगा. Normally only it will reabsorb 85% water, but it will reabsorb 110% water if at all glomerular filtration decreases. It don't need ADH or anything. It will just wake up and start reabsorbing. Someday we should decrease GFR. Just like we apply little hot pads and go to that fellow's room. So how will you decrease GFR? By giving thiazide. What will thiazide will do? Thiazide being a diuretic, it will decrease the plasma volume decrease renal plasma flow, and that will decrease GFR. Immediately proximal tubule will wake up and reabsorb all water, and even if ADH is not available in the distal tubule, still water is being reabsorbed in the proximal tubule. And that is the reason we give thiazide, though it is a diuretic in a diuretic state. To treat a diuretic state called diabetes insipidus is what you need to basically understand. That is the story, doctor. Do you need all this crap to crack entrance? Not really. During my time I got second rank. Like you, I also remembered thiazide is used in diabetes insipidus. Who cares why it is used? But final year MD also we thought it is not required. Because diabetes insipidus is a very rare case endocrinologists come across. Not a regular wala MD general medicine will not come across. But we used to have a brainy guy in our batch. That fellow used to have all these mechanisms in tips. So he used to make us dance. Then he was telling me, this is the reason we give diuretic. Oh, but still we passed exam. So, of course, without knowing lot of things only we will get seat. So that is the reason all our research is in why people get seat in spite of not reading. That don't forget. If they read and get seat, there is no research needed. If they don't read and don't get seat also, no research needed. When do you need research? If they get seat without reading, then we need to do little research and discover. So every year in the first 100 ranks, 80 to 85 students are one or the other place of first 100 ranks in the state entrance or one or the other place, Andhra Pradesh, Telangana, Nellore, Kakinada, Kurnool or somewhere. When we really look into how is their performance on Sunday mock tests, some of the guys were not even getting 70, 80 marks also in the month of July. And we discovered that by the time it is November, they are getting 110, 120. By the time it is January, we discover that they get 140, 145, 150 and never less than that. And ultimately they turn out to be toppers. Some, very few, but that is out of 1800 ranks may 10-15 will show that tendency, but 65 will, from July only they will be getting good score. Okay, that's a bad news for you. Okay, so that is the reason, doctor, if you recognize with every mock test where are you losing, cover up those areas and equip yourself with that filling gaps. By November, December you will do miracles. Every entrance you will crack. Okay. Now doc, there is extensive first pass metabolism for all this but not for gentamicin. So gentamicin, so there are a list of drugs unfortunately, not related to any one of the other. But why they are all brought to commonplace? Because of their extensive first pass metabolism. At least 2-3 drugs you remember, whatever you can, don't remember all. Then, once more, porphyria may givable, non-givable drugs, another list. So, carbamazepine is not safe, but aspirin, pethidine, chlorpromazine, there is a huge list. At least 5-6 such lists. Don't write all those things given in the book. 4-5 definitely will be asked bolke, you keep it and if it comes you answer. Then, what is the mode of action of the various drugs? How does gabapentin act? Gabapentin potentiates the response of the GABA, which is a inhibitory neurotransmitter, and it will block the sodium channels, and that's how it acts like a anti-epileptic. What are the only 2 drugs you can give in absence seizures? Not all anti-epileptics, ethosuximide and valproate. Why only those 2? Because absence seizures are because of problem in T channels in thalamus. Thalamus is there, no? Only these 2 drugs are capable of inhibiting those T channels in thalamus. That is the reason we give only those 2 drugs in absence seizures. Once more, doctor, anti-epileptic drugs should never do mistake. Similarly HIV drugs, you must write in the 200 pages book. Anyway, what I will do is, out of that 1100 topics also, I will further bring down it to 250 or 300 topics. First come, first serve basis. You have to definitely be ready when you go for exam. Out of 1100 topic list given, still I will try to boil it down to only 300, at least read that and go, and still get 80% score. So that is the purpose you are paying us, no? You are not paying us to read more, you are paying us to read less. Now, vasoactive factors. Endothelin 1 is produced because of endothelin converting enzyme, not broken by it. Okay. Then, osteoarthritis may, what changes you have? Herbidens notes, right? Then, Bouteries, swan neck deformity, they are all the problems in rheumatoid arthritis. Then reactive arthritis, what are the various organisms? Chlamydia, Campylobacter and also Shigella. Oh, toll or waves in V1 on ECG, where do you see, except where is the question. I need to throw a few seizures to make you to quickly catch up with this concept, doctor. I will not talk limb leads, AVR, AVL, AVF, 1, 2, 3, वो भूल जाओ, ये क्वेश्चन के लिए बात करेंगे. There are leads, doctor, called V1, V2, V3, V4, V5, V6. Why did I draw like this? Because the heart has a right heart and left heart, and as you go towards left, what are they? V5, V6. In the septum, V3, V4, and on the right, V1, V2. Normally, how will be our mean electrical axis will be passing? From right towards the left, from the top towards the bottom. Okay. So that is the reason when the vector is passing towards V5, V6, any electricity coming towards will lead to what kind of change? Positive wave. And any electrical activity leaving the lead will lead to negative wave. Don't worry, simple electricity आप सब पढ़ के यहाँ है, हाँ? So what is meant by Q? What is R? What is S? First positive wave is called R. Any negative wave before that is called Q. Any wave after that is called S. Don't worry about this negative waves. I will take care of it. You only remember about positive wave. अगर आप PCG खोल के देखें तो V1 में पॉजिटिव वेव होगा या V5, V6 में पॉजिटिव होगा? Why? Because electrical activity is passing towards left. So you don't expect a huge and tall R wave in the V1. अगर R wave हुए तो कहाँ होना? V5, V6 में होना. And that is a normal phenomena called R wave progression. Good R wave progression. Suppose somebody is having R wave prominent in the right sided lead V1, V2. What does it mean to say? If it is positive R wave, it means to say right ventricular hypertrophy. It means to say right ventricular hypertrophy. And of all these conditions, which can never lead to right ventricular hypertrophy? Epstein's anomaly. Why? What is Epstein's anomaly? Epstein's anomaly means between right atrium and right ventricle, the tricuspid valve is positioned little lower level and in a narrow way, right? And because of that, the blood cannot flow easily into right ventricle. Instead, what will it do? There will be an ASD through which it will go into left atrium and go into left ventricle. So who is bearing the ultimate brunt? Left ventricle. Who is escaping? Right ventricle. So if it is not having any work, will it hypertrophy? If it doesn't hypertrophy, will you have R wave in V1, which is a right sided lead? No. So you don't find R wave in the right sided lead. V1 is what you need to remember. Okay, doctor? We will end with medicine because 3 o'clock Dr. Gautam will be taking up the surgery class. So people need to eat a little to rejoin the class. Now vagatonic maneuvers in SVT. Simple. Whenever right sided carotid is being massaged, then sinus rate will slow down. Left sided will impair the AV nodal conduction. This is the important rule about carotid sinus massage. Then in ASD, what do you see, doctor? Pulmonary plethora, because from left atrium into right atrium, blood is going into right ventricle into pulmonary vessels. But which vessel? Pulmonary artery arises from right ventricle. नहीं मिला. Point मिला या नहीं मिला? What happens in ASD? Right atrium, left ventricle, right ventricle. From left atrium into right atrium through ASD, blood will go into right ventricle and it will go into pulmonary artery. So pulmonary artery become prominent. So what the plethora you see on the chest X-ray is because of pulmonary arterial plethora, not the venous plethora, is what you need to remember. Where do you find pulmonary venous engorgement? Suppose you are having mitral stenosis. Left atrium blood is jammed and that will back pressure on pulmonary vein, and you will find pulmonary venous engorgement in case of left ventricular failure or mitral stenosis or anything that increases the pressure inside the left atrium lead to venous engorgement in pulmonaries, because pulmonary vein drains into the left atrium. Whereas ASD, VSD, PDA, in all this there is increased blood flow into pulmonary artery and pulmonary plethora is what you need to basically remember. Yes. Dilated cardiomyopathy. If you take the alcoholic myopathy, what is it? Predominantly left-sided failure, not right side. Then left atrial myxoma will behave just like mitral stenosis. Mitral stenosis में diastolic murmur or systolic murmur? Mid-diastolic rumble. So you find not a systolic murmur but a diastolic murmur. Then hemolytic anemia में what will basically will happen? Hemolysis will release the hemoglobin. Hemoglobin will bind with haptoglobin. Haptoglobin get exhausted. So there is a decreased haptoglobin, not increased haptoglobin. What is the most common form of the shock? It is the hypovolemic is most common. Always giving fluids is important in hypovolemic shock, not giving inotropic agents. And if it is a cardiogenic shock, what is important to give? Inotropic agents, not the fluid. If the heart fails, you give fluid, means you are finishing the patient. Right? Then dialysis is not effective in which situation? In case of digoxin poisoning. Why? Because digoxin is a highly protein bound drug. If the drug is highly protein bound, is it filterable? No. If it doesn't filter, it can't be dialyzed. So that's the point to be remembered. So you must know the list of dialyzable drugs and poisons. Microangiopathic hemolytic anemia, where do you have? Hemolytic uremic syndrome, TTP, etc., etc. In alpha thalassemia, what happens if you do electrophoresis? So basically, doctor, what is adult hemoglobin? Alpha beta. What is fetal hemoglobin? Alpha gamma. Right? What is HbA2? Alpha and delta. Alpha and delta. Okay. Now, if you are having beta thalassemia, beta is not produced. Right? If the beta is not produced, still alpha is available, no? So if this alpha goes and binds with delta or with gamma, what will happen? There will be increased HbA2 and HbF and decreased Hb, adult hemoglobin. Is the situation where in beta thalassemia. But in alpha thalassemia, alpha itself is not there. So regular hemoglobin is not produced, fetal is not produced, A2 is not produced, none of them will increase. All will be decreased if it is alpha thalassemia, but only A2 and F selectively increase with the decrease in adult hemoglobin if it is beta thalassemia. That's a point. Electrophoresis helps to make the diagnosis is what you need to remember. Which is not a feature of hereditary spherocytosis. Biconcave disc has a greater surface area, spherocyte has lesser, so there is a decreased RBC surface. Okay? Then megaloblastic anemia, these are all the causes but not amlodipine. बीच में amlodipine क्यों आ गया? It's a idiotic option. I mean, I say questions. So what is the famous saying? Even a non-working clock also will show the time correctly twice. Even if the clock is not working also, 2 times it will show time correctly only. No, if it is stopped at 10 o'clock, it will every time 10 o'clock comes, it is correct time only. No, without the preparation also, you can answer 40%. if you are not even an average student, matlab you bring a school going 8th class student and give him a PG paper, entrance paper, 40% he will correctly answer. Then you are anyway did something in medical school, no? In addition to a lot of other things, little reading also you did know. So you should definitely score 55%. All our effort is what? From 55 to 75. Only 20 you have to improve. इसके लिए don't overread. If you overread, once more score comes down. Because if you are overreading, no, you will discover that there are too many things that you did not read. Then also your performance will come down. So don't overread. Then, what is first investigation? Thrombocytopenia? Another idiotic question. If thrombocytopenia is there, will you do lipid profile? You won't do, no? You will do platelet count. So if you know thrombocytopenia means low platelets, we will pass you, doctor. So, which is not a side effect of blood transfusion. Blood transfusion, if you give, there is a hemolysis and release of intracellular ion, potassium, and lead to hyperkalemia, not hypokalemia, is what you have to basically remember. Okay, doc. So with this we will call it a day. Remaining things you can go through the explanation. And next Saturday, what is the subject test in the schedule? Pediatrics. So read well all developmental milestones. When will the babies dance, jump, walk, sing, triangles, quadrangles, everything. We will have a Lagatar discussion. Thank you.